Pilon fractures, high energy fracture, classified by Rudy Algauer. Rudy Algauer's principles. Number 1, fix the fibula. Number 2, maintain the length. Number 3 is bone graft. Number 4 is reconstruct the articular surface. There are some important fragments when you have a pilon fracture. Number 1, medial fragment. This is attached to the deltoid ligament. Number 2, posterolateral fragment. This is the Walkman fragment attached to the posterior inferior tibiofibular ligament. Number 3, anterolateral fragment. This is attached to the anterior inferior tibiofibular ligament. Number 4, a possibility is Wagstaff, when fibula is fractured at the anterior inferior tibiofibular ligament. The surgical intervention: span, scan, and plan. Span to reduce and immobilize, scan for planning, and plan how to fix. Delta frame is a bridging ankle external fixator with salmon pin into the calcaneum, 5 mm pins for tibia and 4 mm for the metatarsal. The calcaneum can be fixed with denim pin. Oblique pin in the first metatarsal to avoid deep dorsalis pedis artery away from the injury. When soft tissue permits, that is wrinkle sign, distal tibia contoured locking plate. Reduce and fix fibula first to restore the length. Reconstruct the articular surface with temporary K-wires and then lag screw. Convert C to A and then place together. 3 fragments: anterolateral, Chaput, anteromedial, deltoid, posterolateral, Walkman. Fill bone graft or graft substitute. Reattach articular block to the metaphyseal and shaft. Circular frames can be used with poor soft tissue quality. Problems: complications: wound breakdown is an infection in 30% of the cases. Prevent with external fixator and delayed ORIF. Post-traumatic arthritis needs arthrodesis in 10% of the cases. Stiffness and reduced level of activity. Varus malunion. High rate of wound breakdown. Delayed ORIF until soft tissue envelope gives chance. Non-union. Risk is anterior tibial artery and deep peroneal nerve. Anterior approach to the distal tibia and ankle. Wait for swelling to subside. Skin to have wrinkles. Similar indication for total ankle replacement. Preserve more than 5 cm skin bridge if you are fixing fibula. Incision 1 cm lateral to the tibial crest and follow the medial border of tibialis anterior. Curve medially 110 degree at the ankle joint. Incise extensor reticulum. Intermuscular plane EHL and EDL. Between the EHL and EDL. Retract EHL neurovascular bundle medially and retract EDL laterally. There is a risk of superficial peroneal nerve. Neurovascular bundle is between EHL and tibialis anterior, proximal to the joint, and between EHL and EDL distal to the ankle joint. So neurovascular bundle is between EHL and tibialis anterior, proximal to the joint, and between EHL and EDL distal to the ankle joint. Medial variation 15 cm incision, anterior to medial 15 cm anterior to the medial malleus. Dissect tibialis anterior and neurovascular bundle and retract them laterally. Incise deep fascia to medial side of the tibialis anterior. Deep peroneal nerve and the anterior tibial artery are at risk. Avoid above joint runs between EHL in EDL, crosses behind EHL at the level of the joint. Posterior medial approach to the distal tibia ankle. Landmark halfway between the medium malleus and tendo achilles. Plane is developed within tibialis posterior and FDL. Tibialis posterior is tibial nerve and FDL is tibial nerve as well. 10 cm longitudinal curved incision in concavity pointing anteriorly. Risk is neurovascular bundle, posterior tibial artery and nerve retract posteriorly with FDL and FHL. Anterolateral approach to the distal tibia. Distal tibia fractures. The incision is parallel to the fourth metatarsal and between the tibia and the fibula. Internodal sprain between the peroneus tertius, deep peroneal nerve, and peroneus brevis, superficial peroneal nerve. Superficial peroneal nerve crosses incision in subcutaneous tissue immediately under the skin, can be extended distally to talonavicular joint like Ollier approach. Cannot access the medial malleus. Use pre-contoured anterolateral plate. Lateral approach to the ankle, direct approach to the posterior border of the fibula and can extend distally.